First of all, very happy to share some thoughts and some techniques with you, with two things to share. First thing is on distal thrombectomy, secondly some stuff that we're thinking are interesting for AVM analyzation. Distal thrombectomy, I'll try to, okay, which vessels to recanalize, it's a question where we still don't have the answer.
Maybe you close this thing because it's taking this way, you know, just keep it anywhere, and there's a small...
I'll try to take it off.
No, but
does that not want?
Not there.
I don't know how to take it off.
You know, there's like a little...
No, but
there.
Okay. Good.
How many doesn't go from there?
Do the same thing. You take the left one.
That one.
Okay. Good. So, which vessels to recanalize? Probably we don't have the answer for this. We have some answers, of course, for the studies that have been done for the low-hanging fruits, but it does not mean that the others do not need to be recanalized, or maybe they don't, but at least we need to evaluate this. So studies ICA, RTT, M1s. What about M2s? M2s is a kind of gray zone because they were supposed not to be treated, but they were treated in different studies. And now I read articles that are sent in for publication where distal thrombectomy is focused on M2s, and I don't think these are not the patients I want to discuss about, because stentriever in our practice are systematically placed in M2, never in M1. So to say that M2 is a distal thrombectomy is not really what we consider. So patients I want to focus on now are either PCA and ACA, or the second question is how far to go. And for PCA and ACA, we have some growing evidence that it works. There's no reason not to work. Just like MCA, even if the studies are small sample studies, retrospective, and the difficulty is in fact that we're not facing so many patients with isolated occlusion of ACA or PCA. Usually it's a mixed pattern, but having only patients with ACA and PCA is not so frequent, so it's going to be more difficult to have a large group of patients to evaluate. Another issue with those patients is when we're talking on TICI score. TICI is focused on MCA. And if you reopen an MCA and the PCA and ACA is occluded, those patients are just rated TICI3, which does not make sense. Which means that our way of thinking and of scoring has to be changed to have a TICI score for MCA and for ACA and for posterior circulation, not only PCA but of course basilar too. So probably this is a confusing factor which makes analysis of the patients we're talking a bit difficult. Same thing for clinical evaluation. So ranking score is focused on motor function, not only, but this explains the difference in left and right MCA occlusion, where the left MCA occlusion will always have more ranking than the right. And it's poorly adapted to evaluate PCA and ACA. So again, our way to evaluate clinically is more difficult. But from the technical point of view, there is no difference if you go in M1, M2, A1, A2, P1, P2. It's the same stentriever and the same navigability for the 21 microcatheter, even if ACA may be a bit more difficult than MCA. I mean, if you close your eyes, push the wire like a J, it will always go to MCA, not to ACA. So it's a bit more efforts, but still it's something which is reachable for the very large majority of operators. So this was a way to answer for PCA and ACA. No doubt that evidence is going to grow, that there is no reason to keep those vessels occluded and not to reopen them. Specifically, the risk is not higher because the diameter is the same. To the question how far to go, this requires other issues, and maybe this example of this patient with an MCA occlusion, you see here it's an embryonal origin of the PCA, the ACA, both are fine, but both superior MCA and inferior MCA branches are missing. The superior MCA branches is reopened after first pass. The inferior is reopened too, but I go back to previous image. Between this here and there, obviously we lost some clot in the ACA. So it's an ENT, embolus normal territory. It's a problem that we created, displacing the clot from one branch to the other one. Now it's getting better, but an important part of frontal lobe is still missing. So we may say frontal lobe is not so important. There is still no doubt that it's better to have it than not to have it. So if we created, why should we keep that occluded? And this is before, and this is where there are 1, 2, 3. And after the clot migrated from here to there, because this was missing 2, the callosal marginal reopened. And here I tried a 21 microcatheter that did not navigate, a 17 that did not navigate, but finally a smaller headway duo, so 1 point French microcatheter, not a 1.7, enabled to go there, to take here the smallest device available today. So this is here Tiger 13 that enabled to reopen. And technically was more the difficulty to bring a smaller microcatheter and a smaller artery. And here's a little fish that is caught there. So Tiger 13, compatible with indeed very small catheters. And the interesting thing is if you push the device with a catheter, you don't feel the resistance. So if you push a stentriever in another microcatheter, the last 10 centimeters you have to fight to push it in. And here you must take care, because if you don't look at fluoroscopy, you will go through. And you have a handle where you can play to open something, and this gives you more of control if it's not something which is given at a given diameter, but that you can play yourself. It's good to have this argument to play with. Here's an example.
Do you guys understand that? Yes. This is like a nitinol balloon, if you will. So what he's saying, do they handle them? They think if you open it, click it just a little bit, you can only open half of it. So it's not like an automat.
And even if when you try to open it completely in a small vessel, it won't, but still you adapt to the size of the artery, so it makes sense. This is a complication that I created. I treated this aneurysm with flow diverter, and I did even something more. And I lost here a part of thrombus. The aneurysm is just occluded, but also a branch. And, well, you don't want to create an embolus, knowing that this patient has dual antiaggregation, which also potentially increases the risk here. But if you have a device that goes up to there, where you deliver the stentriever, you play with the system to open, close a couple of times, and then you take it out. It's obviously better not to create a stroke than to create a stroke. And you see the befores and afters where this has been taken out, and you see we did not create any bleeding on the CT, which is done immediately. So now I report on a series we just published a couple of months ago, 105 patients, where we've been using this device for distal arteries beyond M2s or distal ACA and PCAs. And the rate of bleeding is not small. The rate of bleeding, 45% is a lot. But this
I think you should call it extravasation.
And that's why we call it here extravasation, not bleeding, because the CT is abnormal, because we've been doing something in small vessels. But if you look at SAH, which is a blood next day, then we just have 7. And not 47, so most of it is almost nothing, but also symptomatic intracranial hematoma, which were 8. So we may have some issues, and this figure here is not small, higher than what we would have been expecting, because it's more dangerous to go into smaller arteries and larger ones. This is here to differentiate. This is how we try to categorize. This is a typical picture when you've been going beyond the Sylvian point, so up to M3, where a little bit of something is to be seen. Next day is normal. This is here SAH, where next day you can see a bit of blood, but this is minimal. And here we call it hematoma, where we have a more significant amount of blood. But in the end, The prognosis of those patients is usually related to ischemia and stroke, and most of the bleeding cases are luckily not relevant. So a couple of comments on this, because we could discuss it for hours. Of course, smaller vessels means less clinical impairment, higher interventional risk. That's why the question is really raised whether those patients should be treated or should not be treated, and we don't have the answer. But when we are doing a procedure, and I'm not talking of patient that comes spontaneously with an NIH of 1 that will not get a thrombectomy, but when you're having a patient with sticky 0 that you open at 2A, 2B, and then you see a clot in M3, the question is, I think, raised whether we should reopen it or not. And if you do it, then you must do it in the optimal conditions to reduce the risk. And optimal conditions is to take the smallest possible device. And I fully disagree with the concept of doing aspiration there, because aspiration is the largest possible device. And if you put the largest possible device in the smallest possible artery, you increase the risk of situation where you enter into conflict and you create the damage. So if you want to go on distal, reduce the risk, take the small thing, under optimal conditions, which means you must see very well what's going on, and the patient must sleep. If he does not sleep and is moving, it's impossible to push a wire blindly, because you're sure that you will create a bleeding. And some level of experience is also important. If you've never done any thrombectomy, then it's not the moment to start going to the small vessels. You must have had, I would say, 2 years of experience of thrombectomy, created enough of other complications to know, to have some feeling of what is dangerous or not before you go on to small vessels. Another point is which indications and whether patients receive IV lysis or not is a point to consider. Patients that receive IV lysis are likely to have those clots being treated by lysis, but an increasing number of patients that we treat did not get lysis just because criteria for lysis are not met, because criteria for lysis today are far more restrictive than criteria for thrombectomy. So if patient receives thrombolysis, we would rather be cautious. Of course, if the artery which is affected is a frontal artery or functional artery, but if the patient sleeps after NIH, after TK0, you won't be able to know. But if you see that it's an artery to the central sulcus, then it makes sense. And of course, uncomplicated regimen, because if the patient receives an extracranial stent because of tandem occlusion, then he will have monointerrogation, and this is a good candidate to treat. But if the patient receives an intracranial stent, then we need a dual interrogation, otherwise intracranial stent with thrombose, and under dual interrogation, getting into the small arteries increase a lot the risk that a minor bleeding continues to bleed and does not stop. Comment number 3, this is a Sylvian point. When you reach up the mountain and you go down again. On the AP view, so the Sylvian point is something which is very precise, very clear, and this differentiates M2 from M3, and since this point, things go dangerous, because when you deliver a stentriever, regardless which stentriever it is, this is here not a tiger, catch me, that works on well, while pulling on this, you have a resistance because of the clot, because of the stentriever, and pulling brings here the Sylvian point down, and bringing the Sylvian points down tears the transmedullary arteries that are connected here to the Sylvian point. And if you pull too much, this will bleed. And that's why when you pull on here, it should not bring that down. Maybe we need another vector of force with an intermediate device here, or at least something which aggressivity and resistance to pull is very low. And I think that the Tiger 13 is quite good for this.
So if you get that position, how do I bring my system back? I mean, this situation.
You have to pull on it.
And
that's why the stentriever which is in place must have a stentriever with low friction. And the low friction is something like the device we're talking on. And if you take a regular solitaire entrevo, then you will have a high friction and this point will be brought down.
Also, the advantage of the 13 is that it's much softer when it comes back.
So this is not brought down so much. An interesting point in getting into distal, the superior division branch of the MCA is the one that gives this angulation. The inferior division branch of the MCA doesn't have it the same way. The PCA and the ACA don't have this angulation. So if you consider 4 arteries, ACA, PCA, superior MCA, inferior MCA, the one which is dangerous is the superior MCA. All 3 others are not. And all those concerns for the Sylvian point are not existing, and then you can adapt your technique according to this. So in other words, the more dangerous to treat and to be more cautious is the superior division branch of the MCA. Now a comment specific on Tiger 13, how to use it. It seems that if you play with it, you open, you close, you open, you close, you may break the clot or you may help embedding the clot, which means having the wires getting through the clot. Another thing is there's a compromise between the degree of opening and the level of resistance. So usually we open it maximum what you can see. So we count the kicks, kick, 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 6, 7 or 8. And then if we've got 8, we don't want the system to be maximum expanded. So the friction to take it out is higher. So we reduce it by half, kick, 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 4 kick down. We reduce a bit the amount of opening, so it will be more easy to take down.
Would you also expand the stent and wait a little bit so
it seems that it's a good thing. I usually don't wait for proximal, but for the distal one, waiting is a way to help embedding the clot. So waiting for a couple of minutes makes sense. Yes. Here is again a picture.
Are you guys waiting when you put a stentriever?
Yeah, 3 to 5 minutes.
3 to 5 minutes?
For this one, we used it this morning, we did 2 minutes.
Yes, and we never wait. We never wait for all proximal. We never wait because there did some work on this, and the time for embedding clot is still less than 1 minute. So the time that you prepare everything and aspiration, I don't think you need to wait 5 minutes. 1 minute should be enough. But for distance,
we're doing something else. We're pushing very.
So the counterpart is what Ahmed says, is to say that you're pushing on the device, because if you deliver it, you've got some level of opening. But just like a stent, flow diverter, if you want to be well open, you push on it, it increases the radial force, increases its ability to expand, point 1, and point 2, then we pinch the clot. Why does it work, the clot? It's because it's open like the hands. I will push my camera on again. I don't know if it works, but I'll do it like this.
So make it bigger.
And
take the thing which is talking.
Okay. And here. So
you
and pinching means if you close the stentriever like this. By closing the stentriever, at least partially, if you completely resheath on the clot, you lost it. But if you close it, the ability to grab the clot is much higher, which is the principle of using of a stentriever dedicated for white clots that we're using since 1.5 years, which is called the Nimbus, developed by Johnson. And it only works if you pinch systematically. So for each stentriever maneuver, once it's placed, you push on it to open, so you don't need to wait. And then we pinch, which means you start to close it, and here you see you grab the clots or whatever, get the clots in between the wires. This is the reason why it works. Okay, other comments, and maybe very important. If you go into distal, you must be very precise. To be very precise, you must know exactly where the clot is, which means once you pass the clot, or you presume to pass a clot, you must do an angiography distal to the clot. And usually we pull on the clot.
How do you know you distal? You get blood flow back?
No, so I take my catheter back up to the point where I can see it. And then you can see from the proximal and from the distal injection where the clot starts and stops, in order to deploy the shortest length of stentriever just there. because what is toxic and aggressive is the length of strentriver. So you can take different stentrivers. In the end, what counts is the amount of strentriver which is out of the microcatheter. And this can be adapted. Here's an example where you may see that something is occluded, but I don't remember where it is, so we're going to look at it again. Here it's occluded. Can it be right? Is it right? Or where is occlusion? This branch here is too slow. At this level, I hope that you can see my mouse. This is too slow. So here we're bringing the microcatheter, which is a headway duo, which is indeed very small and very navigable, together with the traxis wire, I would say. You see the tip here. I hope that you can see it also on your screen. And then, okay, you follow the course. If it's too much bended, then you can just push the catheter alone. And at some point, we're still in M2. And at some point, we take the bifurcation branch. And here, okay, here is a point where we lose the artery. Now the catheter is following, and now we're in the occluded segment down the Sylvian point. And once the wire is in, you see you can push it, but of course this patient is under general anesthesia, it's not moving, so you can see where you are, and this is an artery going somewhere close to central sulcus. Now we're beyond by shore, but I don't know where the clot stops. So here I inject under fluoroscopy, and I see, and you see here is the tip of the clot. You don't see the vessel anymore. So now I repush, and usually the catheter makes it spontaneously. Here, interestingly, it goes to another branch. So you see that the clot is, as always, located as a division in the division branch. But we're in one division branch, we're in the other one. You know where the clot is, and now you just know precisely, and it's not much effort, but you see what you do. You can locate it precisely. Now here, the Tiger 13 is in place, and we're opening and closing it, which was not obvious to be seen, and then we retrieved it and seen that the artery, yes, you see the territory which is here, reperfused, which was a functional territory. So these were some comments, and I think that it's an evolution of our job in doing thrombectomies, and once you reopen the proximal arteries, it's impossible not to think of doing the distal ones.
So you're recommending with distal thrombectomy not to open the full length of the stentriever?
Absolutely. The shortest length, the better it is. But if you take another one, if you take a catch-mini, for instance, then pinching is super important. Catch-mini does not work without pinching, but with pinching, you close the stentriever up to the point, and then you must block, of course. You must take care, because if you retrieve the stentriever, then you lose a clot. And then usually you got a clot this way. And the shorter the segment of stentriever to be out of the microcatheter, the less friction to retrieve, the less straightening the vessels, and the less complications.